Just because apologies from Catriona and Ron Guns is probably joining later, I think.
Okay. Well, folks, welcome to this meeting. I'm chairing today's Highland Health and Social Care Committee owing to the absence of Jerry O'Brien. Jerry's currently on his way to undergo an operation, a planned operation, I should say. So we wish him success in his operation and a speedy recovery. He'll be back to chair as soon as he's recovered, but that might take a matter of weeks, if not into perhaps a month or two. So speedy recovery to Jerry following his operation. So welcome to the first meeting I've chaired as the vice chair. And do we have any apologies other than Jerry, Stephen?
Just Catriona Sinclair and Ronald Gunn is joining later.
That's fine. Okay, and we'll move directly into the agenda with declarations of conflict of interest. Any declarations? No, none. That's good. And
Philip, I think Pam is trying to come in. Sorry to interrupt. I don't know what she wants to say, but she's got her hand up there, I can see.
Apologies.
I didn't want to interrupt the flow, Philip. I was just going to wait till you're finished. Just to say that Claire Copeland, our Deputy Medical Director, is on the call. She's over in Skye and she's driving, so she'll be listening. And hopefully if we need her to directly chime in for anything, then she'll need to get into a lay-by if we've got any specific questions. But she is listening, she is driving, and she is engaged. Well, thank you.
Welcome to Claire, and yeah, thanks for the assistance for the hands. I'm not very good at observing those, so if I do miss any, please give me a nudge. And if we move on to the next agenda item then, which is the assurance report and action plan from the 15th of March. So that's in the combined papers. Do we have any observations or issues with regard to the assurance report? Nothing? Okay. And in terms of the action plan, I see that there are two outstanding actions within that plan. One was relating to Jerry was going to meet with the clinical and care governance chair, and I don't know what the outcome of that is, but we'll await for Jerry to come back unless we can shed any light of that, perhaps from you, Stephen.
A meeting's been arranged for when he returns.
Okay, that's fine. And then there's the integrated children's report, where we've got it's added to the work plan in September. So that takes care of the assurance report and the action plans. So next on the agenda, we have got matters arising. And for matters arising, I've got a couple of issues that I would like to raise before we start the meeting proper. My understanding is that Pam has had some discussions with a couple of the committee members with regards to two issues. And I was just going to ask Pam if you can give us an update on those discussions. The first is the Ross Memorial Hospital, where I believe you and Michelle had some discussion.
Thanks, Chair. Yes, we held a meeting earlier on this week to follow up on Michelle's concerns that the work at the Ross Memorial Hospital hadn't started in terms of the fire compliance work and the reconfiguration, and also some concerns around the housing of the rheumatology service with the general adult patients, and concerns about infection control, etc. And that there should have been a project manager appointed for this project by estates. So I went and did a bit more follow-up after I spoke to Michelle. There is a project manager appointed by estates. One of the reasons the project hasn't commenced was that with the work in the National Treatment Centre being concluded, the Scottish Government had asked us not to progress any more capital works so that we could you know, manage our operational overspends, and that work would commence in the new year. So I fed that position back to Michelle, and that Kenny Rogers is leaving on the project. We have a number of engagements around people who use services, local community groups and workforce groups as well. So the project will be taken forward, and we'll take our discussions off into those forums. Thank you.
Grand, thanks for that. I'm sorry, I had my mic switched off there. So in terms of that as an update, Anne, sorry, you've got your hand up.
Did you get, Pam, any sort of estimated start date from estates? I take it we mean in this financial year that we've just started in. Okay, and did they have any kind of target date?
No,
start date?
not at the moment. I'm not aware of any of those dates. However, what is ultimately driving this is the fire compliance work. So in terms of avoiding an improvement notice from the fire service, then they'll be looking at starting that work very soon. But I actually don't have a confirmed date of when they'll actually be going into the building to physically start the work. And I guess it's I can't really debate it here. It's for Kenny Rogers to lead with the staff groups and the operational team over at the Ross Memorial, and I'll catch up with him, and I'll put out an update in my next Chief Officer's report about where we are with the Ross Memorial redesign. Okay,
Michelle, I notice your hand's up. Would you like to come in?
Yeah, I was just going to say ask that this is an update is put forward to the next meeting. Pam wasn't aware of quite a bit of the discussion that we had, and she has come back with some information that wasn't known, but a lot of information that was already known. So it still seems to be up in the air as to what really is going on at the moment. But yeah, I would like to have an update brought back to this committee, please, in June.
Okay, that seems to be a reasonable way forward. So Pam, if we can record that, you'll take an update forward in your next report to the next meeting. That would be good.
Okay, thank you.
Okay, and the next issue within matters arising was to do with the North Coast redesign, where again, Pam, I think you've had correspondence with Michael Simpson in the committee. I know that you had given a commitment to meet with Michael, but could you perhaps give us a brief update as to any discussions or any issues that you can give us an update on?
So I recall at the last committee meeting, Michael had raised some issues around the Caithness and North Coast Hubs redesign. And just at that point, we went in to discuss the district reports, therein containing a lot of information, and I'd fed back about the cross-check events that we were holding up in the north. So Michael and I haven't actually arranged a meeting. I'm not sure if you still want that to take place, Michael. We didn't actually get to that time between committee meetings.
Well, I'm not disappointed in this. I've in the minutes here on page 9, we're going to arrange a meeting regarding North Coast redesign. Then it went on to the Sutherland report, and there was going to be a point in the future we're going to discuss daycare. Now it's what, 6 weeks since the last meeting, and the issues haven't actually gone away. The issues have increased. Callistone is closing. We've got a situation where the daycare centre has just received its payment for this 6 months, but it's actually 3 months because the contract ends in June. The Armadale practice, the GPs are retiring. And I think, to have put it in perspective, that every chief officer, going back to Jill McVicker, has to apologise to me over this. I specifically remember David Park apologising to me. And it rather makes me feel rather cynical that we've spent hundreds of hours and thousands of pounds on engagement I've had meetings with Ruth Fry and Mari McElraith over engagement with communities and that sort of thing. And the whole idea of the North Coast redesign was that it's been left to sort of sit there and vie with Caithness and Skye. And in fact, I get the impression North Coast redesign doesn't actually exist anymore. And I think the people that live up here deserve to be treated better. And in fact, I think I deserve to have a little bit more respect when a chief officer says that she'll contact me over 2 issues, and that's not happened. I'm not normally annoyed about this sort of thing, but I'm extremely annoyed about this.
Okay, well, can I offer my apologies for that oversight then, Michael? I do apologise for that. In terms of the North Coast hubs then, you know, I did attend in person at the cross-check event on the 18th of April last month, and we had very detailed discussions. We had very, very powerful presentations about the redesign that was taking place. So, you know, I will arrange to meet with you to go over that.
Can I just stop you there? I wasn't even invited to this event. In fact, I didn't even know it was on. And, you know, what's the point of me being on this committee as a lay member to represent patients in the community when it's just item after item is just left and I'm not involved in it?
Okay, well, I hear what you're saying. I'm recently in post. I'll make it my priority to contact you and to address the issues that you're raising and make sure that you get engaged into the local community plans, and we can discuss that out with the meeting, if that would be it.
Thank you.
Okay, thank you, Pam. And Michael, I would say we can't speak on behalf of any other chief officers, but certainly Pam's given her assurance to get in touch and to go through any of the issues with you. I have Anne who's got her hand up. Anne, would you like to say something on this matter?
So I think the crux of the issues here, having, you know, heard discussion about this at the committee over time, is that, as I understand it, and I'm a very recent member on the Caithness and North West Sutherland Redesign Programme Board, so I may not be fully up to speed. But as I understand it, I think the issue is that the redesign for the hub in North West, that the commission for that, if you like, appears to be very much around the building, the reprovisioning of Calasona and the building in Melvich, and the provision of a new building. And I think one of Michael's enduring concerns has been whether or not the commission for that redesign adequately takes account of some wider service issues in the area, such as GP provision. Now, obviously, there's a lot of redesign work going on around the patch, and there may be an issue about capacity that we just can't at the moment take forward a wider look at services in North West Sutherland, and we have to, for the moment, just focus on the reprovisioning of the 2 care homes into a new facility. If that's the case, then I think we have to be transparent about, you know, we have to take a considered decision about that and report that situation to the committee. If I've got it wrong and there is the scope to have a wider look at services across the North Coast in relation to the reprovisioning of the building, then great, and maybe we could try and provide the committee with some sort of timetable for how that will move forward. So I think it would be useful, Pam, if you could, you know, in your if you could clarify for us at the next meeting just what the scope of the North Coast redesign is and whether there is the capacity to, you know, have a wider look at services across the North Coast as Michael's concerns suggest is needed. And then we can maybe move forward from there in the context of the next district report for Sutherland. Would that seem reasonable? Unless anybody, maybe somebody else can provide more clarity just now about the scope of the commission.
No, and that seems entirely reasonable. And you know, I've been to one redesign meeting myself, and to the cross-check event. So I'm new to this, so I'll need to get a bit more detail. I know that Jill wants to come in and talk about the primary care services, possibly on the issue that Michael has raised. And I guess I just need to check how we are engaging with the community up there, because if Michael says he hasn't heard about the redesign meetings, the cross-check event, he wasn't invited, then I think I need to go back and sense check the community engagement aspects and revisit that to make sure that we are capturing all interested parties and extending the right invitations to engage.
Okay, thanks for that, Pam. I see that we've got two other contributors wishing to come in. Could we hear from Jill, please?
Yeah, thanks, Philip. I'm more than happy to catch up with Michael outside this meeting as well, because obviously my remit's been involved in the discussions around general practice along the North Coast. I think there is a bit of wider engagement work that we need to do in view of the GP's retirement in Armadale. That practice is going to become a board managed practice from the beginning of July, and obviously discussions are ongoing for that transition, and that's active at the moment. In view of the redevelopment and the new build in Tongue, I think there's a bigger piece of work we need to do to understand community and primary care services, and possibly extend that to the Cape Wrath area as well. So that's something that we've got in active discussion and planning at the moment, and I'm more than happy to meet with Michael out with the meeting and brief him on what our thoughts are around that.
Yeah, thanks for that, Jill. I think that would be useful. And is that something you would like to take up the offer for, Michael?
Yeah, yes, thank you. I appreciate the intervention by the two speakers. I understand the issues. I know the pressures, and they must escalate every day. But I think what I'm really saying is, and if it is a capacity issue, then I think the communities up here need to know that. I think we need to be honest and say, right, we've got Caithness, we've got Skye, we can't fit you in because we haven't got the capacity. And I think they need to know that, if that's the case. Thank you.
Yeah, I would just say that that's not the case. I need to give it my priority and my recent engagement and introduction into the redesign projects. Then I'll make sure that we make that absolutely explicit, that there's shared capacity across all of the partnerships redesign projects.
Okay, and I think a report back, as Anne suggests, would be helpful there. Sarah has her hand up, and I'm conscious that she's been quite patient. So Sarah, did you want to add anything?
Yes, please. Hello, everyone. Some of you on the call do already know me, but a lot of people perhaps don't. So I'm with Healthcare Improvement Scotland in the community engagement team, and I'm the local officer for Highland. So I work to support Marie McElraith as the engagement manager for NHS Highland, and we also have within our team, we have a service change manager who works and supports NHS Highland when it's major service change. So I know Michael had been in touch with me about this, and I took that to the service change manager who covers the area. And I'd just like to say, if I can be involved in any of those meetings, then please could I be invited along, and I'll chat back with the service change manager as well, Michael, about the North Coast redesign, because it is on the NHS Highland website where it lists service changes as to what's currently going on at the moment. But yeah, it was just to let people know that I'm here in that support capacity.
Great. Thanks very much for that.
Sorry, there was two things too. There's just hot off the press. There is two publications. The Planning with People publication has just been released by the government about how to engage effectively and doing it well. But also Healthcare Improvement Scotland, we've just released our quality framework, which again is there to support boards to have a look at how they're engaging, see what they're doing well, see how things could be better. And again, we are there to help them to take a look at that. So if anybody wants that, I can, the link, it's on the website, but I can supply the links if that would help to the committee.
Thanks very much, Sarah, and I'm quite sure that Pam or Jill or both will be in touch to link in to see any assistance that you can provide. So I hope that puts your concerns, or allays some of your concerns, Michael, that we are taking this seriously, and if there's been any disrespect that you felt, I apologise for that, but Pam and Jill will be in touch for the future. So
thank you very much.
That's okay. That's okay. So the last matter. Oh, sorry. Neil's got his hand up. Neil, did you want to contribute to the discussion?
Sorry. Well, without wishing to digress too far, I was just interested in Pam's comment about Scottish Government suggesting that we reduce capital spending and projects, and that's going to affect all of the ongoing redesign projects, surely. I just wondered about a little bit more detail along those lines.
No, that was specifically in relation to starting the work at the Ross Memorial. It was just in terms of finishing off the National Treatment Centre work as we approach the end of the financial year before we started new projects at the beginning of April. So it shouldn't have any impact, if that makes sense.
Okay. Thanks very much.
Thanks, Neil. And I now see that Elaine's got her hand up, and I wonder if from a finance point you want to contribute to this, Elaine?
Yeah,
and if I can just, if I can draw a line under this after Elaine, that would be much appreciated. I'll be getting a row for letting things go beyond our timings before the meeting's properly started. So apologies, folks.
Just to give a bit more detail on the request from Scottish Government. So all boards had a request from Scottish Government around December time, I think it was, requesting that no projects that hadn't actually started commenced during 2022-2023, and this was due to availability of capital overall within Scottish Government. So all that it was really doing was delaying the projects into 23-24. So anything that was delayed last financial year will be picked up and started this year. It doesn't put into any jeopardy the projects that we've got the IEs completed for. We know that those funding streams are going to come online probably around 2026. So there's no concern around funding that's already been committed. What we were asked to do by Scottish Government was delay it into this financial year and beyond. Thanks.
Thanks for that, Elaine. So hopefully that paints a kind of a broader picture for us, and with the reports that Pam will take back to us and the connections she'll make with the two committee members, that should also help with these issues. The last thing I wanted to mention in the matters arising was just in relation to dental services. We've been promised a paper and some discussion on dental services. And Jerry wanted me to highlight the fact that the Director of Dentistry will be at the next meeting, so we'll have a fuller discussion about that in the next meeting. So any other matters arising from any other of the committee members? No, okay, that's good. And we'll move on to item 2 on the agenda, finance. Unfortunately, we didn't receive a finance paper owing to some systems issues. So Elaine is here, who's going to present a verbal report to us, and I'll just pass over to Elaine.
Thanks, Philip. Yes, apologies that there's no formal paper. We're in this period where we're trying to get 2022-2023 concluded. So we're busy working on year end and the final adjustments before we can confidently report a final year end position. So where we currently are, we are reporting an overspend of just under £16 million. So that's compared to the initial plan estimate of 16.272 million. That's a significantly improved position from what we've been reporting in year. But over the final quarter, what we've seen is considerable additional allocations coming in through Scottish Government in the main through New Medicines Fund. But we've also seen a reduction in top slices for CNORIS and some of the contributions that we make to national projects as well. The adult social care aspect of the health and social care partnership will be in a break-even position as we're drawing down the funding from that funding that was held by Highland Council over the 2021-2022 financial year end. At the moment, the health element is looking like an overspend of just under 7 million. So we will bring details back to the next meeting along with some information on the financial plan for 2023-2024. So I do apologise again, we've seen a number of systems issues and there's also been some quite late receipt of information that's allowed us to look at what allocations we've still got to receive and some of the balances and interactions with other boards within Scotland. So we are working hard to ensure that we've got the accounts finalised and that we can get them submitted to Audit Scotland and allow the deadlines for the audit and the submission of the accounts to the Audit Committee and the full board to take place in line with the timetable that we've set out. Thanks, Philip.
Okay, so did you just say that the systems would be able to provide a finance paper for the board meeting next month?
Yeah, we are hoping that we'll get something pulled together for Financial Resource and Performance Committee next Friday, but we are still finalising things at the moment.
Okay, thanks for that, Elaine. Any questions from the committee? Anne.
Thanks, Philip. I wonder then if Pam or Elaine or both of you could say a little bit more about the preparation of the financial plan for this year, how that's coming along in relation to our directorate, and in particular whether we've made any progress in terms of savings proposals.
I can talk to a bit of that. So in terms of our organisation, then we have an efficiency and a transformational change workshop organised next Tuesday, when all of the executive staff will come together with their deputies, so the executive development group, and we will be having a discussion and setting out our plans that we're taking forward in the next year. So you know, really focusing on transformational change. I think some focus and agreement on the board's appetite for difficult decisions that have to be taken. So we will perhaps want a bit of a frame and an agreement around that. Some of the headings that I have is around, we've done some very positive out of hours redesign work in terms of the workforce configuration in Badenich and Strathspey. That's released just approximately £390,000 currently, so we need to make sure that we revisit that redesign across all of our Highland areas within the partnership, and that we share and spread and we learn from the good work undertaken. We've also got cost avoidance to reduce our agency and locum spend. So in terms of looking at you know, removing some of the more expensive off-contract agency workers and getting them on to you know, the more affordable frameworks. We need to develop a lot of services. So some work I'm doing jointly with the acute side around you know, hospital at home, discharge to assess using technology. You know, why are we bringing people into hospital for diagnostics, for example? So looking at developing more of a peripatetic workforce. We also want to do more around realistic medicine and frailty in terms of our frailty strategy. And Claire is listening in on the call, but she's been working very actively out in the community with our clinical leads and our operational managers and multidisciplinary teams about, you know, developing the hospital at home and the frailty approaches that we need to keep. I guess what I would say in one of the discussions that we need to have on Tuesday as an executive group is that we want to keep people at home. We want to provide technology-enabled care. We want to progress all of that, but at the same time, we're trying to maintain buildings and build buildings to keep people in buildings. So I guess we need a bit of a discussion around what is our agreed strategy and direction of travel as we go forward. And I guess it's her appetite for strategic change that, you know, are we being risk averse about? Are we worried about, you know, not having agreement from the government, or the flurry of complaints or issues that will be raised to our local elected members and our MSPs around unpopular decisions we may have to take. So I think that gives you a bit of a frame of some of the work that we're going into. We don't underestimate how difficult it's going to be in terms of transforming our services and providing services within the resources that we have. And the resources are not just money. The resources about affordability, the resources are very much around workforce and our ability to staff a lot of our operations. And, you know, we've seen the independent sector withdrawing from the care home sector. You know, we've had to take decisions ourselves as an organisation around some of the provision that we currently provide. So once we have that discussion on Tuesday, then I would be able to come back with a written up, more robust plan if that's what the committee needs to see.
So I think that's really helpful, Pam, and you know, very pleasing to hear about the work that has been done in Badenoch and Strathspey. Although I'm sure Muriel will want to get some assurance about service continuity and delivery in that respect. So I suppose what just wondering is how what the current timescale is for our ADP process as well, and whether there's a possibility that, you know, that might come together with an opportunity for the committee to sense check those difficult decisions and the strategic direction at the June meeting. I'm not entirely sure. You know, you mentioned the phrase, you know, delivering within our resources, both people and financial, and obviously the ADP is a key mechanism for trying to ensure we do that. So I just wondered, you know, where we are in the cycle with the ADP and if those things are likely to come together for us to, you know, have a useful sense check discussion about the difficult decisions at the June meeting.
So this would be part of our discussion as the executive and deputies workshop that we're having on Tuesday. So I would be a bit clearer in terms of the ADP. I'd note that Rhiannon's on the call. Rhiannon, do you want to give some feedback around the timescales for the ADP and the work that the programme boards are doing to feed into the ADP feedback? Would that be possible? Sorry, it's not an agenda item and we're not prepared to, we haven't been prepared with the information, but if Rhiannon can come in to answer Anne's question, that would be good. Thank you.
Okay, so we've been asked for to submit our next year's ADP, this year's 23-24 ADP in June to the government, so it will go through the EDG group in May. We're also being asked to submit a Q5 update on last year's at the same time as our first quarter for next year as well. So they're our timescales. But in terms of the savings plans, I think what we're what we're trying to do with the ADP is make it a more of an integrated approach, so that we're looking both at performance, finance, and workforce in the outcomes from the work streams in each of those work streams that report through the programme boards. So we're looking at how we template that and get that information through there. In terms of the savings plans, the big decisions that Pam is referring to are not necessarily going to be this year. That we're talking about a 3-year plan. I hope that's helpful.
Okay, thanks for that, Rhiannon. Anne, does that give you a level of assurance about next year's planning and the processes for that?
Well, I think it will be useful to see a report that tries to bring some of these things together in June, so that we can take an integrated view between the ADP for our directorate and the financial situation. So I'll hold off on judgment on that, Philip, till the next meeting. Thanks, but thanks to everybody for their response.
Okay, I'm conscious that Muriel's been waiting for a bit of time to come in this conversation, and Pam also wants to come in. So if I can take Muriel first.
Thank you, and apologies for my delay in getting on. Pam, thanks very much. I think credit in the clarity and the detail that you're giving here, because you have had quite a baptism of fire in the past few months to do that. The BNS project, I think we need to commend everybody that's part of that. I also think we need to recognise the role of Heritage Horizons as well, highlighting the multi-agency work and partnership that's going on. Partnership is overused at times, but there is a lot of work going on, and particularly in this area in BNS, because of the demographic, and I'm sure you're very aware of that. I think what's important though is that we build on the enablement of the people in the area, and because things are going well now, it doesn't mean to say we take our foot off the accelerator, because we know financially the challenges ahead of us. And I would also urge that we work. We are very lucky in that area. Sorry, I'm focusing on an area that I know particularly well, with the locality as well, and that's testament to all the team, from ambulance, nurse leads, physios, everybody, the GPs as well. They need to be part of the conversation as well, because there are one or two wee sticking points at the minute that I will speak to you offline, but they can be overcome just by conversation. I also thought you made me smile when you said about elected representation. I think sometimes there's a lot of, and apologies if I upset anybody here, sometimes there's a lot of hot air from elected members from whatever level that they're at. I think we need to do what is right. And Pam, you have in all the stuff I've dealt with you, Ullapool, etc., you've been very clear, and I think that's what we need to just keep doing, is making sure our message is clear. And if there's something we can't do, we'll get a workaround. So thank you, and sorry for going on.
Thanks for your comments, Muriel. Pam?
No, thanks, Muriel. I really appreciate that feedback, and in terms of working in local areas, making and supporting local communities to be resilient. The redesigns that we've done, particularly in the out of hours area, has been really good and really accepted by the community. So getting our elected representatives on board, to help us get to that place has been really helpful. I just wanted to mention the joint strategy. In terms of the joint strategy that's being developed, we'll be coming out to all of our localities, our community planning groups, our community partnerships, all the user representatives groups, carers groups, etc. A wide consultation and engagement around the joint strategy. And that builds on the work that we've got within the district models. But in terms of delivering on that plan, so we're going to consult on it between June and September widely. But to deliver on that plan, we need to underpin it with a financial plan. So again, around affordability, around a workforce plan, around the workforce we currently have and the workforce we need for the future. So very much looking at workforce development and doing much more in that space. And we need a full implementation plan. So that will underpin what we're doing in terms of our transformation plans being developed and underpinned going forward. So I just wanted to add that in. Thanks, Chair.
Thanks for that, Pam. There's a huge amount going on and a huge amount still to be done. I think we'll look forward to an update in terms of what's happening, particularly around the ADP and the future savings plan. So you've got an awful lot of work that's due for the next meeting there, Pam. I'm conscious of that. So going back to the agenda and looking at the report or the agenda item, as we didn't receive a formal financial report, my understanding is that we're not able to provide any formal assurance for that. So well, thanks for the verbal update, Elaine, and we'll get a full report at the next meeting where we'll be able to take some assurance from that report when we receive it. Is the committee content with that? Okay, thanks very much, folks. And we'll move on to the next agenda item, which is 3.1, Care Home Overview and Update.
Okay, thank you. So I'm going to present this paper, if that's okay. It's a subject that we're very well versed in, and the context that I'm just pulling the paper up, my single screen, sorry. The paper that we have is for members' information, and also the level of assurance that we are reporting is moderate in terms of the actions that we are taking to address the issue. So the report is about the care home sector, and as we know, and we have very much lived experience now and reactivity to the turbulence within the independent sector provision, particularly over the last 12 months, very acutely and recently around the closure of Castle Gardens care home. And particularly over the past 2 years, we've seen the independent sector response to their inability to keep going in the sector with smaller care homes. And of course, in Highland, we've got much smaller care homes, more remote and rurally than other urban areas across the rest of Scotland. So we have had you know, an acute experience of care home closures and the impact of those, and the impact on our flow system between our hospitals and you know, placing people in care homes and delivering care in people's care homes. So as we go forward, we you know, we've got a number of mitigations that we have in place. We've got a number of you know, different meetings and groups and approaches. We are very engaged with the independent sector in terms of being proactive, in terms of supporting them, in terms of having intelligence and hearing very early on as soon as they feel that they're in difficulty. You know, we're so engaged with them that we're able to have a dialogue and see where we can jointly help and mitigate against some of the circumstances that they're experiencing. We have lost, and you'll see in the paper just at the bottom of page 3 of the 6-page report, there's been 4 concluded care home closures since March 2022, and we're currently in the process of closing Castle Gardens care home in Invergordon. That represents a closure of, or a loss to the sector of 143 beds. And in fact, if we look at the current delayed discharges across the hospitals within the Highland partnership across acute community and at New Craigs Hospital, we're hovering about 140 delayed discharges. So really up against it in terms of capacity. I'll just go back to the report. So we are taking a number of actions. Acutely, we're feeling that the current Castle Gardens closure is placing the greatest pressure on our system, and that's making it difficult to identify beds. And then we get into the realms of equity of access, whether you're in hospital or if you're in care home, what's the equity around access to a care home place within an area where the care providers are perhaps not keen even to take people if we offer them incentives, sometimes financial incentives to help with costs. And one of the serious common denominator here is around workforce and the sustainability of services by the sector just because of their inability to recruit. And that's often been a consideration as to why NHS Highland and the Highland Council can't together take on care homes because of the issues that we've already been trying to support and mitigate the care sector about. So in terms of the level of assurance, we're offering moderate assurance for this paper. Although we're not able to individually control the circumstances around the turbulence that the sector is experiencing, we do have a number of things that we can do in terms of working in partnership with the Scottish Government, working with other integration organisations, working with the independent sector to collectively understand and try and mitigate. We've got quite a good understanding of the market. We do have our future model of delivery. We've been looking at residential care and thinking about, enhanced housing support and how we could actually, keep people at home with the right supports in place, some of which I've already alluded to as part of the transformational plans that we discussed in the last item. We've got a good surveillance on issues, risk and impact. We've, in terms of managing the delayed discharges and managing people through the system, we actually have a very senior social worker directly deployed straight into Raigmore. So very visible on a daily basis to try and deal with all of the aspects and the flow out to the community of people who are experiencing a delayed discharge. So, we're looking at, with some monies that we've had from the government that have just come in, we're actually looking at collaborative ways of working and supporting care homes to strengthen the sector going forward and to grow the necessary workforce and multidisciplinary workforce that are needed to stabilise the sector going forward. So I think I'll stop there. I'm happy to take any questions. Grateful thanks to Gillian Grant for collating the report. We were asked for a care home oversight group annual report. So just on that matter, the care home oversight group is coming to an end. That's led by guidance from the government in that we should be more of a collaborative approach, and they've given us money that we're currently looking at to provide more support to the care homes. And rather than being a whole Highland oversight group for the Highland Partnership and our Highland Butte Partnership, we are going to go into what's called collaboratives. So we've got much more engagement around the care sector elements, and particularly the care home support, so that we can address the issues in a multidisciplinary way. So I'll stop there.
Well, thanks very much for that, Pam. There's a huge amount of information there, and it's a really difficult period in the sector, particularly with recruitment and retention. We've already got a couple of hands up who've got questions. So I'm not quite sure who had their hand up first, but I'm just going to do it by the order they appear on my screen. So Kay Oliver, if we can hear from Kay.
Hi, Pam. Thanks for that. I just wanted to ask, in the beginning of the report, you say about how much the costs of and how many care homes are within the NHS and within the private sector, but is there a cost
per resident? Is there a cost difference per resident? It seemed to me when I did a sort of basic maths, it might be slightly cheaper for the NHS to do it in-house, but is that the case or does it vary?
It's actually more expensive to do it in-house, and I'll actually bring in my colleague Simon Steer, who's the Director of Adult Social Care, who will give you the answers around the National Care Home contract and all of the bits and pieces. Simon, do you want to come in and respond to Kay there, please?
Yeah, if it helps, I won't go into the micro detail of every single individual care home, if that's okay. But just for the information of the committee, we have a thing at the moment called the National Care Home Contract, which is the way that we set the rates that we pay. Those rates are around the sort of 850 to 900 type mark of expenditure for buying independent care home sector beds. There are two problems with this. The first is that the National Care Home Contract is currently under negotiation, so that's why I'm not giving you an absolute figure at the moment, because it's a very fragile state of negotiation at this present point. The key thing that members I would ask you to note is that the rate is calculated on the basis of a large care home by Highland standards. So the rate is calculated based on 50 bedded units. In Highland, 75% of the provision is by the independent sector. 25% roughly is by ourselves. So that's changing given the number of care homes that we've had to intervene with. But the key point that members need to understand is we run the majority of the very small care homes. So that means that in actual fact, our costs are beyond significantly greater than the independent sector. Our most expensive cost is £2,000. So we can be well over more than double the cost of care home beds because we're operating the smallest, most uneconomical, most geographically remote. So that's, I have to say, that's a round cost. I'm giving you round cost because when we take into account the staffing issues that we've described earlier on and the use of agency, etc., in places where we find it very difficult to sustain staff, then the actual costs, as opposed to the budgeted costs, actually go up even more. But summary for you, NHS Highland running a care home under the current circumstances is usually significantly more expensive than the independent sector.
Thank you.
Thanks for that, Simon. I'm conscious that maybe strays into some of the areas that we have on a substantive paper with regards to care fees and charges. So some of that gets picked up there.
The other thing I wanted to say was in regards to Invergordon, I don't know if it was staffing issues that brought the closure of Castle Gardens, but obviously there's also another care home in Invergordon. There's the day centre in Invergordon. There's Key Housing in Invergordon. So in terms of one small area, there's quite a lot of jobs in that sector. So when staff are possibly more reluctant to travel for work, in terms of cost of transport and things like that, then that would put a strain on things in one particular area.
Yeah, and would you like to comment on that, Pam? Or I noticed that Simon came back with his hand up. So Simon.
Yeah, I'll allow Simon to comment. Thank you.
Yeah, thanks. I'm conscious of time, Chair, and to be honest with you, Kate, happy to have a conversation out with on account of the fact that we could probably use the whole of the committee to discuss the pressures that are around in care at the moment. But to give you a very quick summary answer, it's not just one area; it's the entirety of the Highlands. Any care home, really, without relevance to sector, is suffering from massive challenges in recruiting and retaining staff, massive challenges where they can't recruit and retain in the cost of agency, which is then having to be used, which significantly increases the cost that they're required to to pay out. There's other aspects of general inflation, fuel and insurance being two particular areas that are causing massive pressures on the sector. And then finally, there's also a number of significant issues that relate to both building age, building maintenance, and also building compliance with the regulatory framework. In a nutshell, all of that is what is causing care homes to close. And then the final bit is, of course, that the wages that are able to be achieved within the care sector are not necessarily keeping pace with other areas such as hospitality, etc. I could give you a huge lecture on this, but if it's okay with you, in the interest of time, I'll keep it at that summary. Is that okay, Chair?
No, that's great. Thanks for that, Simon. It is a big issue, and I think there's a lot of people who want to say something on that. So there's a couple of hands up. In fact, there's 3 hands up. So if I can take Michelle, Cara, and then Anne.
Thanks, Pam, for that report. My concern is at each meeting we find that there's another care home being closed, which, as pointed out, it's a serious problem. On page 2, it says it's simply not feasible for NHS or the Highland Council to step in all circumstances, and nor are such developments necessary within the control of NHS or the Highland Council. My question is, should further closures happen and it's not feasible for NHS or the Highland Council to step in, then who will become responsible for these residents in the care homes and where will they go? And is there any work being put into place, or, in the event that, this problem is going to become a reality? Is there anything being put into place to overcome this? Or does it fall back on families?
No, it doesn't. The care of the residents in the care home is our first priority, and will always be. We do have an agreed way of looking and assessing the viability of care homes going forward. We've agreed that between NHS Highland and the Highland Council through our partnership arrangements. So we assess each individual home and closure on its own circumstances, whether it's to do with workforce or the state and the maintenance of the building going forward. Also, we must be positive and think about the opportunities, for changing the staffing model as well, where we've had a small care home closure, and we've looked at a redesign. So if we look down at Dalmore, for example, we had some respite and residential people in there. When faced with having to close the service, we were able to change the operating model to people working more peripatetically and able to support people in their own homes. So we have to look at all of the economic factors, as Simon has outlined, but also look at the workforce redesign and the support in communities that we need to do. So it's not a decision that we take just as Highland. We are the lead agency. We have the services delegated to us from the Highland Council, but the Highland Council still retain their statutory responsibility. It's up to them to provide care homes. So in partnership with them, we have discussions around the building states, the opportunities to purchase care homes to keep the service going, and also we can also partner with other sectors to look at other providers coming in if we want to actually lease and or buy, if we want the council to lease and or buy buildings on our behalf, so that we can continue to provide the care. So all of these discussions take place. All of those processes are in place, and I guess that's reflected in the assurance level articulated in the paper.
Thanks for that, Pam.
Thanks, Pam.
Conscious of time, so we'll just move straight to Cara.
Hi everybody. I'm chair of the Adult Social Work and Social Care Committee, and I think Simon's right. I think it's a topic that you can talk about a lot. We talked about it at the last committee meeting, and I think there was a number of concerns from the committee members on this specific area. And one of the topics that we were talking about was just about that sense of what the future is going to look like. And I was just reading in the report what it says: there is a clear direction of travel for future delivery, quality care home provision in locations where they can be safely, sustainably and affordably resourced. And I think that was a conversation from the committee members, really just about what is that sense of direction, and maybe their concerns about what does that look like and the impact that that's having on adults in the community, impact on delayed discharges, and noting some of the, like with Castle Gardens, for example, the level of need for the individuals that they supported and the reduction in that overall. So I think they were just maybe looking for a bit of a sense in terms of that direction about future delivery, and it would be helpful to understand a bit more about that. But I think you've described it in some level, Pam. Thanks.
Thanks for that, Cara. And finally, we'll take Anne. I'm conscious of time, so if Anne can be our last contributor in this bit.
Oh, okay, thanks, Philip. So first of all, I think just to say thanks and acknowledge the amount of work that will be going on across the board in relation to the homes that are closing and the relocation of the residents. You know, that does put a huge additional strain on a stretched system in managing that process. So I think I would like to ask the committee to acknowledge and thank those that are involved in finding alternative homes because that's what they are, homes for the residents. So my question really is around the risk assessment piece in the paper and the three issues raised there. And I wondered if we, well, A, how are we assessing system impact in the round? What sort of issues are we looking at? For example, how successful are we being in retaining staff within the system? How far are people having to relocate? I note that the current IPQR data for delayed discharges for a care home is 30. And are we, you know, what would be the current assessment of the status of that risk at the moment? And I just wondered specifically on Calasona, that wasn't really on the list of expected issues that came up just 6 weeks ago at our committee meeting. So I just wondered what had happened there, whether an opportunity arose in terms of relocating residents. Obviously, long term, we were very much aware that, you know, closure would be happening. But in terms of assuring us about the processes that we have for horizon scanning, I just wondered if somebody could clarify just what the specific issues that arose in recent weeks were. Thank you.
Okay, so in terms of the answer to risk, we do have a paper later in the committee around risk assessments and how we manage risks. The risk is annotated within our risk register. I would need to go and look at the detail and to tell you what the risk rating is, but it is actually annotated and is present within DTEX and within our areas of surveillance that we have. In terms of Calasona, you know, it is expected as part of the Caithness redesign and North Coast hubs earlier than expected, purely because of sustainability. So one of the key issues for us was about people's experience of care. So the home only had 3 residents in it. They were subject to, you know, trying to staff the home with a succession of inconsistent agency staff. So their inability to, it wasn't about receiving good quality care, it was about their inability to receive consistent care and build up relationship with their carers. The home had a lot of difficulty over the winter pressures trying to sustain workforce levels and substantive workforce. Likewise, Melvich was in the same position. So from a quality perspective then, and for a people's experience of care, and to be honest, the current workforce experience of care of inconsistent colleagues and not being able to work with people consistently, the decision was taken along with the state of the building at Calasona, which was needing significant repairs and redesign. And you know, we were into difficulties with the care inspectorate actually tolerating some of the fabric and layout of the building in terms of the quality of service we needed to provide. We took a decision to close Calasona, to move the residents over to Melvich, and of course that's all part of the redesign and the moving forward plans to build the care home for future residency in Highland. So I would give that as the two answers to the questions, and I'm really conscious of time.
Okay.
Well, I think perhaps we could. It wasn't really specifically the detail of the risk register I was looking for. It was, you know, a kind of strategic assessment of the system impact. But I'm happy, you know, to leave that till maybe a further update at the next meeting, Philip, and move on just now. So maybe
Yes.
Pam, if we could, you know, get something maybe in your chief officer report next time round, which says a little about what our current assessment is of system impact and what data we're collecting or looking at to assess that. That would be helpful. Thank you.
Absolutely.
Yes. Certainly the concern would be the speed at which the circumstances kind of brought forward the closure, and any mitigation that we're currently using in terms of any wider or further closures, how effective those are, how effective they can be, and we can maybe cover some of that in the next paper. And just before we move on, Anne said the committee would be like to thank those that are providing the alternative provision, and I think it is incumbent in the committee to make that clear, that we do have an appreciation for those that are involved in providing alternative care when closures occur and when alternatives are put in place. Okay, that has moderate assurance in the report. Is the committee quite happy to take moderate assurance from the report? Okay. Thanks very much. And we'll move on to the Learning and Disability Services Assurance Report. Who's speaking to this one?
That'll be me. Hi.
You're here.
Okay.
Thank you.
Yeah, thank you. Hopefully, committee members will have a time to read through the paper. So I'm conscious of our time. So what I'll do is I'll just give a brief overview and then have time for discussion around about this. So this paper around about the Learning Disability Services focuses specifically on individuals with complex needs. That usually are individuals with a learning disability who also have mental health issues, autism, or challenging behaviour. We're moving away from the phrase challenging behaviour, and we're starting to talk much more about individuals who have behaviours that challenge services, so that actually it's our ability to provide the support that they require rather than actually a presentation from themselves. Those are individuals particularly who require 24/7 support, who often require 2-to-1, 3-to-1, potentially even at times 4-to-1 staff. And so the 4-to-1 represents the 4 members of staff supporting the one individual at any given point in time. Not usually 4-to-1 24/7, often it's that there are peak periods or there are specific targeted times when we're providing that support in order to enable them to complete a particular activity. The housing that the individuals require, or the accommodation, is usually very bespoke, and it's usually designed in order to meet their needs. It can include things from high fences and additional soundproofing, careful consideration about the location of the individual's houses, and 2 exits from every room, for example. It's usually delivered in cluster settings, and in Highland we have a number of what often people refer to as core and clusters, but actually don't have a core. A core element refers to a staff base, and a cluster housing is usually 5 or 6 houses built next door to each other. It looks like a cul-de-sac. You've probably been driving past many cluster housing sites across Highland without even knowing that actually the people that live in those houses are people with very complex needs that we're providing 24/7 support to, which is exactly how it should be. People should be able to live in their communities without everybody knowing where they live and who they are. The that model is a model that is supported by the Scottish Government, and we've been guided by the Scottish Government to kind of to provide to people since the days of closing Craigfadrick, and that it has been well researched as known as the most effective and the most sustainable model of delivery of support over the years. What has happened in Highland as time has gone on is there are several cluster housing around, but as you can imagine, it takes a long time to go from the planning element and the design to have them. So they only come on stream every few years, and often in between that time, an individual themselves will go into crisis. And that could be, for example, a young person who has lived at home with their mum and their dad, who reaches kind of 18, 19, 20, and suddenly they're a big strapping lad or a very fit young woman, and mum and dad are saying to us that we can no longer provide the care and support to this individual, please help us. And at that point, in order for us to move the person out of their family home into their own home, we often have to take what is called an isolated tenancy, where we work with the council in order to take a house that's going to meet the person's needs, and then we work with our support providers in order to provide that support to the person in their home. It's much less sustainable than those the models that we have when people live in cluster housing, partly because staff find it more difficult because there is nobody nearby necessarily who can help if a crisis occurs. And therefore it becomes a very intensive model where the only person you're supporting is this one individual over what is usually 12-hour shifts, and is usually the way that providers set that up. And I'll come to what we're doing in a moment then. All of this work is overseen by the Coming Home Implementation Report, and I think I spoke about that at the last committee meeting when I talked about the learning disability assurance papers, and that report, you can see from the links, is there for anybody who would like to look at it and provide some really specific recommendations that they're asking for Highland to be involved in a bid to enable us to ensure that we can bring people back from out of area placements for individuals with complex needs, but also for people in their local area to maintain and to continue to live in their local area. Highland has been fully involved in that report. We are part of the pilot project for the Dynamic Support Register, and a couple of our team sit on the national work that's moving forward around it. For those individuals in Highland, or who belong to Highland, who are currently in out of area placements, so you can see from the report that we have 9 individuals in hospitals out with Highland, as well as the 6 people who currently are in New Craigs, and we have 4 individuals who are living in hospitals out with Scotland. Not all of those individuals can be returned to Highland or Scotland. There are some individuals who are on what we would call a forensic order, and there are particular reasons why they're placed there. It's difficult to give you the detail within the report without making people identifiable, so we kind of, it's why we're speaking to the report perhaps in more detail. What we have done, we've done a significant amount of work in Highland in order to be able to bring people back into Highland in line with the Coming Home report and in line with previous Scottish Government reports. And one of our most recent development is around in Muirford, where we worked really innovatively, kind of first people in Scotland to do it, to work with a company called Safest Houses, where we designed and built a brand new build in Muirford. It's opposite the RA Care Home. If anybody's driven through Muirford recently, you'll have seen the work going on, and that work is now complete. The keys were handed over to that build earlier in April, earlier this month. And there's a little link within your report. If you click on the link, it'll take you to a fancy wee video which can kind of show you a sort of bespoke CAD drawing of what the insides look like. We designed that building alongside families with 2 individuals in particular in mind. 2 of the flats are much bigger standards, space standards, than any other flat. So 2 of the flats are 90 square metres, and then the other 4 flats are 45 square metres, which is actually, I think, the 55 square metres, because they're above what Highland Council space standards would be for a 1-bedroom flat. It's all under one roof, so that we have learnt from some of our previous experience and some of our other cluster buildings where staff find it easier to provide support in a crisis when they are not in a house next door, they're actually somewhere within the building. We're kind of going for a posh concierge type approach. It's not a unit, it's a housing model. People's housing benefit will pay their rent and they will have security of tenure if their support provider changes. We did a tender for the support provision. We did all of that in line with good practice. We worked with families. We learned from our previous experience. We wanted to have a provider who was currently working in Highland so that they weren't also setting up an entire new management structure when they came in, as well as providing support to people with complex needs. And we did all of that within good time. Key, however, I would probably say almost heartbreakingly so, have been unable to recruit the staff that they require in order to provide the care and support that these individuals need. And therefore, to date, no one has been able to move in to their house. We would be expecting, usually at handover, the first person moves in within the first 2 to 3 weeks of us taking handover. We are unfortunately unable to fulfil that. That links to, and I think it links to the last paper that you heard about, around about the current challenges within care homes and at the care and home sector. It's exactly the same within the support sector. We're experiencing the same challenges about our providers and their ability to recruit, and they're having the same conversations with us as they are about care at home, around about their financial concerns and around about their staffing concerns. The other element of the paper is around about health inequalities, which is about the NHS director to deliver health checks to people with a learning disability. We've had a meeting with the Scottish Government actually this week, and the Scottish Government are setting up some new learning networks across Scotland to ensure that each board area is able to meet the directive, which would be to provide health checks for every person with a learning disability, including those individuals with complex needs, and have provided a budget of, which I've stated there, is of £46,000 per annum in order to deliver that. We've recognised that that's a very difficult challenge to achieve within the budget that's there, without this significantly impacting on the other care and support that we provide to individuals. So, for example, if one of the models was for our learning disability nurses to do that, and achieve this directive, then that will impact on their ability to provide the support that they do elsewhere in their other models. Therefore, what I have done is I've offered the committee limited assurance today. I think actually from the point of view of health checks, I would offer that as moderate assurance, but the significant concerns that we have about our ability to provide care and support to individuals with a learning disability and complex needs particularly, and despite the plans that we have in place, we can only offer limited assurance at this point. But I'm happy to take any questions and perhaps reconsider that if the committee wish me to.
No, thanks very much for that, Arlene. There's a lot of information in that, and plus it's gratifying that we've got a new build that we have in Muir of Ord, a bit concerning that we're unable to staff it and get residents in there. And just a very short answer, if you're not able to answer it, then I understand that. Do we have any expected timescale for having it staffed and residents centering?
We don't. We did have an expected timescale of the beginning of June for one individual. The meeting I had at the end of last week is leaving that very much in doubt, but that would be with and so the contingencies and the mitigations that we're attempting to do in partnership with the sector, for example, are around about using agency staff, where they use agency staff, and then when their own staff come on board, they drop the agency and put their own staff in, and there's a kind of sense that if people are actually supporting an individual, that may attract staff, and we might start sort of the ball rolling that perhaps it's the initiation of this. Agency staff are now proving to be more difficult to commission. It's not for us to do that. It would be the support provider that would do that, and now they're telling us that they can't get agency staff, which is why my assurance is so low. I've never known for us not to be able to get agency staff in that situation.
Well, thanks for that, Arlene. And you do say that it's limited assurance, so I'll just remind the committee that on the basis of limited assurance, we will have a further report coming back. So anybody who's got any questions that go beyond what you've provided there, we will get another chance at this, although I've got some questions already. And if I can take Michael first.
Yeah, thank you for that, Arlene. How much did this unit or these units at Muir of Ord cost?
So it has no cost to NHS Highland. There's no capital cost because it's a tenancy model, and so therefore Safest Houses have built it. And then what they do is they lease it to a registered landlord. We have a very clear agreement that that the tenants will work with a registered social landlord, and they lease it to the registered social landlord, and the registered social landlord get the money back through their housing benefit. There's no
But if it's
capital
empty, the
cost to us, which
landlord
is
won't be.
part of the innovation.
But if it's empty, the landlord won't be making any money.
So we have so there is an agreement from the very point of it being handed over as part of the kind of the bigger overarching deal, if you like, is that the first 3 months there would be no void costs. After 3 months, then there is an agreement that NHS Highland will start to pay the void costs if we can't get anybody in. And we have that for all of our properties for individuals with very complex needs, because what we can't do is take the risk that that goes back into kind of common use, if you like, and then the very specific design and build that we've worked so hard over has Joe Bloggs living in it, when actually we know we are still going to require that kind of accommodation. So yes, there is a financial risk around about both the risk around the agency costing and the void costs which will come upon us.
Yeah, I just find it a very, very depressing scenario that this sort of circular and obviously doesn't just apply to this, it applies across the board. And I just think, we need to pay our staff, more. I know it's very political, but if we don't start paying them more, then we're going to go from a crisis to catastrophe. I know it's not your problem. It's just a general point that I feel about this is we can't carry on with specialised units, with care homes, the independent sector. I mean, there's thousands of pubs that have closed in the last year. There's one hotel I saw recently, the energy bill was £30,000. It's gone up to £170,000. Care homes must be the same. Specialist, obviously, it's a specialist unit that's got high insulation. But, these are issues. And if Simon wants to give us a long lecture sometime and he's got time, I'd appreciate it. Thank you.
Thanks for your comments, Michael and Arlene. I think it's very valid that, that we can't retain staff, we can't attract staff, and there is a wider issue that's involved in that. So if I can just go back to the questions in the committee, and I have Kay, Muriel, and then Simon.
I just wanted to say, first of all, that I noticed that a couple of people are at Northgate Hospital. I worked there for many years in the art department, and it is built on a village model. I just thought the committee members might be imagining this old-fashioned hospital or something like that. So it's on the edge of the town. It's what they called villas, which are small units, like a cottage with 6 or 8 bedrooms, a living room, and everything like that. So the small units, there used to be a sort of somewhere to go to work, like laundry, shops, hairdressers. So it's a village model. And one of the things that was slightly concerning me was, are we bringing people back to the Highlands to be isolated in a house when they, and has there been an investigation in what activities they're doing within the hospital at the moment, to make sure that those activities and things are replicated when they move to perhaps an more isolated area? Because I think Northgate must be about 10, 20 acres or something like that. It's a big place where they'll have lots of things to do and things to go about and lots of freedom, whereas being in a small flat might be more of an issue. So there's that point. I don't know if Arlie wants to say something about that before I go on to the next one.
We maybe hold on to those thoughts, and we'll get Muriel's question as well, and we can maybe answer a couple of things at once. So were those all your points, Kay?
No, I've got a few. The issues about staffing, obviously, the key housing's experiencing a huge problem because the changes in the day service provision in that area has meant that all the clients that used to go into the day service during the day now need maybe it's one-to-one support during the day. So they've had to recruit an awful lot of staff just to maintain their service. And also the changes in the day service provision has meant that more agency staff are used for self-directed support. More the staff that are in the day centres are working more one-to-one or with small groups. So there's more staff needed in the day centres as well. So the whole knock-on effect has meant that lots of people are recruiting at the same time, which has meant a shortage of staff. And the other point I wanted to make was about training of the staff for the house, because I've known in other service provision, you get staff in and you spend a lot of money training them to work with specific clients, and then they leave, and then you have to spend a lot of money training them for specific clients again, and then they, so it's a knock-on effect. So who is going to be paying for the training? Is it the NHS going to have to input in the training, or is that the agency staff that are going to be working with the clients?
Thanks, Kate. And if we can just hold those for just now. And Muriel, did you want to ask some questions as well? And we'll try and mop up the answers in response.
Very briefly, I thank you, Arlene, for that, for the clarity of that report. I presume we're on the risk register with this, as that's one thing. And the other thing I was going to ask, will this delay or stop developers developing more safe houses because of the challenges we're facing? Because we hear often that we're requiring more of this type of property. And do you and your team need support from council, and again the collaborative approach? Because I'm really concerned about this.
Thanks, Muriel. I'm conscious we're about 20 minutes behind as it is, and we've got hands from Simon and Cara. Are both of your hands up to provide responses, or have we got further questions? So, Cara, have you got further questions? Yeah. So
I did have a question, but I'm happy to ask the question to Arlene out with a bit. It was more just about the bottom of page 7. It talks about the review of people in isolated tenancies, and I know that I had previously been involved, and I'm thinking it might be linked to an SBAR that I had completed some time ago, and I was just looking more in terms of what the plans are around that and for an update in the future, because I know that there been a previous discussion about looking at isolated tenancies and what future outcomes might be for individuals. So I was just more interested in, just because I'd have some previous involvement.
Okay, thanks for that, Cara. If I can then pass to Arlene and/or Simon to give responses to the questions posed by Kay and Muriel, that would be appreciated.
I mean, will I give a specific response? I assume you have a kind of more generic element that you wanted to bring in the conversation. Okay, thank you. I was waiting for your head to nod there. So Kay, just very specifically around about Northgate, the individuals are in the new build specialist Mitford unit, which is a very specialised new build for individuals with complex needs, which is quite different to the other areas of Northgate that perhaps from when you were previously working there. Our team have worked very closely around about the transition plans, as we always do when we're bringing back individuals with complex needs. It's a very long process. Our staff go down and spend time down there along with the new staff there. So we have very carefully considered how people would experience their new life, and that it would be and we've got a lot of past experience of doing this, and people's quality of life is massively improved when they live in their own home as opposed to living in an institutional place. The other questions that you had, I think, were around about training, etc., and that all comes as part of the commissioning arrangement. And I think that's actually quite a detailed answer. If you want to pick that up in more detail and better understand how we commission support and our relationships with providers, I'd be happy to do that, but perhaps separately, because I think that, conscious of your time. Muriel, I think your point is absolutely, we are struggling with that at the moment. We are having conversations because of the timeline around the time it takes to build new builds. And we are sitting looking at 2 sites at the moment for potential new builds and sitting considering whether actually do we do this or do we not? Because if we can't actually recruit staff, we are creating additional risk there. I don't think it's reached the risk register quite yet because it's been a growing risk, and I think only in the last couple of weeks have we realised just how significant the risk has reached, and so therefore we will make sure it is added onto the risk register. But I think we're going to have to think very, very carefully about what the long-term plan is here, because even if we can find a solution and a mitigation from moving forward, the trajectory is not positive, and I can't see how that's going to change. And I think for me, the options that we're starting to discuss will impact on other individuals, and that's the part that we're going to really have to consider carefully to come back to.
Thanks, Arlene. Simon, do you want to mop up anything that's been left?
Yeah, it was just dead quick on the back of Michael's earlier comment. The danger when we start talking about the kind of care homes and indeed care at home and staffing, etc., is twofold. One is and I'll say is with Arlene here relating to this item particularly, the danger is we tend to talk about older people, and we need to remember that support services are very challenged, and also that when we talk about residential care homes, those apply to younger adults as well as older adults. And the second is an offer to yourselves in the committee, rather than do this in committee, which will use up a lot of your valuable time. I'm very happy to do a briefing outside of this with committee members, going through some of the challenges that we've got and some of the solutions we're trying to find, not for decision, but really for your awareness, and give you a chance to poke around it if you want in a more informal environment. I'm very happy to do that for you.
That's very useful. Thanks for that, Simon. And that might be something that we can build into a development session. I don't know if we have space within any development sessions, because I think we've got quite a number of issues that we're looking to look in detail at. But thanks very much, folks. If I can just draw this item to a close, because I'm aware we're quite substantially over time now. This is for limited assurance, which means that we will have to have a report come back to the next meeting. It would be particularly good if some of the issues that have been identified in our questions and the committee's questions can be addressed within that next report. And I'll just ask the committee, are we content to take limited assurance from this report? Got some nods there. Okay, thanks very much. And we'll have a short break. I'm conscious that the agenda says a 10-minute break. If it's all right with everybody, if we can have 5 minutes just for a comfort break, and if we can come back for 20 to 3. So I shall see you. Apologies for such a short break. It's just I would like to move on if possible. Thanks very much, and we'll see you in 5 minutes.